Hello class, this is Babu Dan. I'm pleased to be able to join you through audio narration of PowerPoint presentations made for the Oxygen Therapy Seminar for Biomedical Engineers and Technicians at Arusha Technical College in Arusha, Tanzania in December 2020. Oxygen is vital and the brain knows that. The inability to breathe creates more patient anxiety than profuse blood loss and pain, because the brain can only survive a few minutes without oxygen. In fact, it's so important that the lung and heart work autonomously to provide brain oxygen. It doesn't take conscious intervention of the brain for these systems to work. So the emergency care starts with the ABCs. First, checking the airway to make sure it's clear for breathing, then establishing the breathing, and finally, circulation. So, choking obstructions might be one thing to clear. And then finally, forced breathing can be an emergency response. It can be either involve mouth-to-mouth resuscitation or ventilator application. Finally, you stop bleeding, although that can be done normally, simultaneously with the others. Blood loss doesn't hurt a brain-dead patient. So often, the panic reaction of a patient causes hyperventilation, a combative patient that actually makes matters worse. Now we'll discuss some of the diagnostic, therapeutic, and monitoring devices that are required for a respiratory distress response. We mentioned clearing the airway is priority, and we do this with a laryngoscope to first see what is in the throat. Then an aspirator or suction pump can be used to clear either secretions or the obstruction. And finally, there's a check for respiratory rate breathing. Now, this is done manually initially and then is done with a patient monitor. And that can be done by measuring the impedance across the chest, which will change as breathing happens. We use a pulse oximeter to monitor the blood oxygen, and that is the oxygen that actually gets into or gets to the brain. And then an emergency response may be to administer supplemental bottled oxygen by nasal cannula as long as the patient is able to breathe. That doesn't work if the patient is not breathing on their own, in which case it may be necessary to intubate the patient and force air into their lungs using a ventilator. That involves placing an intubation tube directly into the trachea, bypassing the epiglottis to make sure that the air gets into the lungs and not into the stomach, because the airway is common to both the stomach, esophagus, and the airway to the lungs. A face mask is not effective for unconscious ventilation, as ventilator-enforced inspiration can pass into the esophagus and into the stomach, causing a vomit reaction to choke the patient. Intubation is a very traumatic remedy, so it's something that is not chosen lightly. Let's assume that the airway has been cleared and the patient is still not able to breathe on their own. If they can't inhale or exhale, supplemental oxygen as delivered through a nasal cannula is not going to do any good. This is a case where intubation will be necessary and a mechanical ventilator will have to do the breathing for the patient. This is perhaps the most complicated piece of medical equipment that any technician will deal with, because to understand ventilators, you have to understand thermodynamics and fluid dynamics as well. The physics is quite complicated, plus the physiology of how you set it up for different lung compliance conditions that are due to different diseases is very specialized knowledge needed by a respiratory therapist. So once intubation has happened, which means a tube bypasses the epiglottis, which is the thin fold of skin which normally keeps any kind of food from going into your airway, into your lungs, the intubation tube basically ensures that the air from the ventilator is going to go into the lungs. No chance of it going down the esophagus. So the ventilator breathing rate is set. The tidal volume, which is the amount of air that goes into each breath, is set based on the ideal weight-height ratio of the patient. Inspiration time is set, and sensitivity for patient trigger of inspired breath is also set, as well as alarms for peak pressure. Now, we will cover ventilators as a separate PowerPoint because that is really important knowledge and also something that oxygen analyzers are needed to calibrate, because many of these devices have the ability to set oxygen percent into when mixing supplemental oxygen into the ventilated breath. And so the analyzers are necessary not only for oxygen concentrators, which can deliver nasal cannula oxygen, but also for testing whether ventilators are delivering the controlled amount of oxygen saturation to the patient. Aspirators are portable suction machines that can be used to remove secretions such as mucus and saliva that may be obstructing the airway, as well as small obstructions. They do have in common applications for removing blood during surgery and other multiple applications of a portable suction machine. The control elements of an aspirator are basically a vacuum regulator plus an on-off valve, as well as a suction catheter, which usually has another on-off valve, which can be used to apply or remove the vacuum. Now, the vacuum source is typically a compressor. The intake to a compressor creates a vacuum, just as the output creates a pressure. So this is something that is common to to all pneumatic devices, is that compressors are generally one of the things that technicians need to service. The other things that are necessary to service are making sure there are inline hydrophobic filters that prevent any of the fluids from the patient from entering the vacuum source, entering the regulator, or entering the compressor, because this can clog valves and is most frequently the reason that an aspirator will stop working or not perform at full vacuum. The service and calibration of aspirators and suction machines generally involves cleaning and replacing filters. If necessary, adding an inline hydrophobic filter between the suction collection container and the vacuum gauge and compressor to ensure that no liquid can get into either of those. And then also to check and compare the vacuum gauge on the device with a digital pressure vacuum meter to see how accurate it is. If it's low, identify the leaks and replace tubing as necessary. It may be necessary to clean or flip leaf one-way valves in the compressor. Typically, in many devices, especially Gomco, the compressor itself has leaf spring valves, and these can become clogged if material from the patient gets in and dries. So generally, you need to see the service manual to see the actual service procedures. But it does require some type of external vacuum pressure gauge. And at Arusha Technical College, we have a high-end gauge that is accurate to 0.1% provided by BC Biomedical Group. So in summary, an aspirator or suction pump removes obstructing fluids, blood, mucus, pus, in the mouth and throat for respiratory distress, or any other part of the body during surgery. Compressors create a vacuum at the intake And a pressure regulator will be used to control the amount of vacuum that is created. The vacuum and pressure gauge needs to be checked for calibration, and in order to do that, you're going to have a reasonably accurate external pressure vacuum gauge. Leaky hoses, containers, and valves can reduce the vacuum, and that is what is most likely to fail on these devices. But bodily fluids which enter the compressor or the regulator can involve reduced valve seal and can affect operation. Second in our list of emergency medical devices for respiratory distress is a video or manual laryngoscope, which is used to, at minimum, illuminate the throat in order for the responder to identify obstructions. And in the case of a video laryngoscope, it will actually improve the image. The alternative is simply an optical, old-fashioned laryngoscope, which has an illumination source. And that is relatively easy to maintain. The video one, there's not much you can do in terms of service. Again, for most of these devices, all you can do is clean the device. And check the batteries, of course. Here are two examples of manual and video laryngoscope. These are both curved. Another option is to have a straight shaft. So in summary, a manual or video laryngoscope is used to observe and clear airway obstructions in respiratory distress, and also to place endotracheal tubes in the case of intubation. They involve routine cleaning with manufacturer-approved solvents. Don't use anything that the manufacturer does not approve. Make sure you do a battery status and date check for video units. A dead battery can mean a dead patient. And check for proper video operation. The tracheal intubation tube is not a serviceable item, but it's something that a biomedical technician and engineer needs to understand the function of to appreciate ventilation. Technicians have to understand the function of endotracheal tubes, even if there's no service involved. These are used for intubation in a patient that is not able to breathe, inhale, or exhale on their own, and they involve insertion with the aid of a laryngoscope, and then inflation of a balloon which will seal off the passage and ensure that the air can be forced into the lungs without leakage. Pretty simple summary for an endotracheal tubes. They form a tight airway seal for mechanical ventilator use with a patient circuit. The balloon seal is inflated by the clinician after insertion, and they're not reusable or serviceable.